Greetings. My name is Doug Krakauer, and I'm from Beth Israel Deaconess Medical Center in Boston, Massachusetts, and the Fenway Institute and Harvard Medical School. And I'm really pleased to be talking with you today about a topic that's near and dear to me, which is HIV pre-exposure prophylaxis, or PrEP. And we're going to be talking about over-the-counter PrEP, which is hopefully an exciting new way to think about implementing this wonderfully potent HIV prevention tool that's been underused so far. And the title of my talk is Opening the Floodgates to Empower Patients. And I hope that at the end of this, you'll see that where we are now is not where we need to be in the future, and that there are really exciting possibilities for implementing PrEP. So I want to start with a story about my very first patient that I ever prescribed PrEP to. This is about 6 or 7 years ago, and I'm an infectious disease physician, and this was a young man in his 20s who identified as bisexual, and he was just starting to explore his sexuality and having more condomless sex with male partners. And he had heard about PrEP, but really didn't know how to get it. And he eventually kind of worked up the nerve to talk to his primary care provider about it. And he was a healthy person, and his primary care provider really had very little familiarity with PrEP, hadn't heard of it, had never prescribed it, didn't really know where to start. And so they eventually figured out that they could refer to me, who was someone who was interested in this. And I saw this young man, and he was incredibly busy for his job. He was traveling all around the country, and it was very hard to kind of schedule an initial appointment. But eventually he got in to see me, and we got the labs done, and we met, and he was a great candidate for PrEP, and he was very excited about it, and it really was going to work well for him. But it took a good month or two for him to kind of get in to see me. And because he traveled so much for work, it was really challenging for him to follow up with me. And there's a certain amount of follow-up that needs to happen in terms of lab studies and clinical visits. And over time, it just became harder and harder for him to do that. And he was completely lost to follow-up. This is a bunch of years ago. And this is someone who really was benefiting from PrEP. And to be honest, we never got in touch again after he lost touch with me. And in my mind, it's actually quite plausible this is exactly the kind of person who really could be living with HIV right now, for all we know, because of the benefits that PrEP was offering. And the lesson I learned from this story is that the way we administer PrEP in the clinics, with all the barriers in terms of scheduling, insurance, in the United States, there's a lot of obstacles and barriers to kind of jump through, the challenges of people getting refills. It's just a lot. People have to take off days of work, or they have issues in terms of their busy schedules. And so what I'd like for people to think about and to open their minds to is the possibility about what if we remove these obstacles. I mean, these obstacles are challenging for this person who had a great job and lots of resources, and eventually kind of navigated his way through the healthcare system to find me, who's sort of a PrEP specialist. But what if we think about, particularly for patients and populations that have been underserved by PrEP thus far, in terms of populations where poverty and underinsurance is an issue in the United States, in terms of race and ethnicity and income, there are populations here and globally that have really had underuse and under access to PrEP. So let's imagine a world where we throw away all these barriers and make PrEP extremely accessible. Couldn't this actually combat not only some of the access issues for most people who are already thinking about PrEP, but open this up to a wider population? And so in terms of equity too, I think this could really be a way to get more people engaged in PrEP in an equitable manner. And this is the idea of over-the-counter PrEP. And so think about all the things that this patient, or people in settings all around the world, all the traveling they have to do to get to a clinic, to jump through hoops to get PrEP. Now, that's where we're at. But think about a future where someone could just walk into a pharmacy on their own time. They don't have to take a day off of work. They don't have to find a clinician. They don't have to have what is often an awkward conversation about very sensitive personal issues in terms of their sexual orientation or sexual behaviors, their partnerships, their condom use. Those conversations are tricky, oftentimes we know that some clinicians, in terms of their training, are actually quite judgmental in the way they handle these conversations, and then they're thinking about who may benefit from PrEP. And so there's a lot of shaming that can go on, and patients feel that, and that's another barrier to PrEP. But imagine you can walk into a pharmacy, totally private, not have to see a clinician, no scheduling hassles. You don't have to worry about being judged by a clinician. You don't have to do a lot of things in terms of insurance, but if there was low cost, generic tenofovir disoproxil fumarate emtricitabine, which is a pill a day, and it's actually a PrEP that works for pretty much any population that may benefit from this. And if you imagine the shelf next to all the vitamins and the aspirin, all the other things you can walk in and get, what if we did that for PrEP? And I think this would actually potentially open the floodgates and empower patients to come in on their own time and their own accord. And I think this could take what is now a very underused intervention and increase access, equity, and impact. And it could happen in a realistic way. And there are great analogies, I think, to think about this in terms of parallels with contraception. So contraception is a really important sexual health tool that has a lot of parallels to PrEP in my thinking. And so contraception has been around for many, many decades, and in ways it's kind of decades ahead of implementation as compared to PrEP, but there are a lot of similarities that I think can help us think about, well, what would over-the-counter PrEP look like? Well, let's think about over-the-counter contraception. So just like with PrEP, contraception is something where there's a clinician gatekeeper in places like the United States where it's by prescription only. And there are the same issues in terms of adherence to pill taking, continuing and persisting with contraceptive technologies to get all the benefits. There are many modalities in terms of oral pills. There are injectables. So again, lots of similarities. There are rings that elute contraceptives. And so what can we learn from contraception and the path that it's taken towards over-the-counter status and what it's like to have over-the-counter access to contraception? And can we leapfrog with PrEP? Instead of waiting the decades that it may take to catch up, can we kind of go and leapfrog forward a few years? So let's shift our thinking to where contraception, the kind of parallel tool is in terms of over-the-counter status. Well, there are a bunch of countries around the world where you can access oral contraceptives over the counter. And people have wondered, I think, in the US about this. Well, will people actually use it with the same benefit? Will they adhere to it? Will they continue it the same way if it's over the counter, as opposed to going and see a clinician where there's some oversight and conversation with a provider, which could potentially keep people engaged? And so there's actually a study that looked at this really important question, which is quite fascinating, and I want to share with you. It's a study that's kind of like a tale of two cities. And this is a study that people did in El Paso, Texas, and a city right over the border from the United States and Mexico called Ciudad Juarez. And these are the two parallel cities. You can drive your car 15 minutes from El Paso to get to a pharmacy in Ciudad Juarez and vice versa. But in the United States, oral contraception was available by prescription only. And in Ciudad Juarez in Mexico, it could be acquired over the counter. And so people wanted to study, what if people could access it? People could actually go right across the border from El Paso and access this by walking into a pharmacy or even having their friends or family go and pick it up for them. And so it was a great kind of natural experiment to see what the difference is in people's preferences and their use and their continuation of the same exact modality, but right across the border, and a lot of cultural similarities. And also the main difference being, is it over the counter or by prescription only? So researchers did some qualitative interviews with women who were accessing contraception through both modalities in El Paso and in Ciudad Juarez, and including people who drove across the border to get it over the counter. And what they found in qualitative work with some of these women is that some women prefer accessing their oral contraceptives in the clinic setting. They liked seeing a clinician and getting it that way. And the main reasons when they asked people and they surveyed them is that there were other health services available. They liked the quality of care they were getting in terms of general primary care, other kind of reproductive, obstetric, gynecologic care. So they thought that the full package was really a benefit. They also thought that the pills were cheaper if they had insurance in terms of cost as opposed to going to over the counter. That was their perception, at least. And they really trusted the information that clinicians could provide. So again, this idea of they thought they were getting maybe better quality of care by seeing a clinician. So those were really valuable benefits. On the other hand, there were some women who preferred over-the-counter access. And when they asked those women what they liked about it, women thought the pills were cheaper in terms of cost if they could just go in and pick it up. And a lot of the people in the study were from populations with underinsurance and low financial means. And so this idea of walking in and paying for generic contraceptives right off the shelf was really attractive to them. They thought that it was actually going to be more expensive through insurance. They really liked the convenience and the privacy of not needing a doctor's visit. They could just go in their own time. They didn't have to share anything about their sexual behaviors or their personal health, and they could just do it. And people saw that as one of the main benefits of over-the-counter contraceptives. And they liked the idea in terms of convenience that family or friends could just go pick it up for them, didn't have to take days off of work, things like that. So there were people on both sides who liked it, which I think supports the idea of why don't we have both as an option for these sexual health interventions like contraception. So then the big question is, well, were people continuing to use the pills if they got over-the-counter versus prescription, which can inform a lot about the thinking with PrEP, because I think people might worry if we just let it be over-the-counter, will people use it kind of willy-nilly and not adhere to it, not persist, and therefore not get the benefit, maybe even cause harm. And what the researchers found was really fascinating is that people who accessed by prescription, about 25% of the women after a year stopped using it in terms of discontinuation. So 75% would continue it. But for people who got it over the counter, only 21% discontinued. So similar numbers, statistically actually more likely to continue it if you accessed it over the counter as compared to in a prescription, presumably because of this convenience question. This is, when I read the study, I was quite surprised and encouraged by this because I really didn't know what they would find. So that opened my eyes to the idea that, in fact, maybe the benefits in terms of continuation adherence are actually favoring over-the-counter, or actually because they're similar enough, maybe we just need to have both options. So that was really interesting for pills. And what really blew my mind when I kind of did a little more research into the contraceptive world is that there are actually higher continuation rates of self-administered injectable contraception, like DMPA, which is worldwide one of the popular forms of contraception, where it can be clinician administered or people can inject themselves, and it's this kind of every several month injection. And there was a study in Malawi, and continuation rates were far higher with people self-administering. 73% of women continued using the injectable contraceptive if they self-administered, as opposed to only 45% in terms of clinicians if you look out on that order of 9 to 12 months. Similar study in New Jersey, here in the United States, 69% continuation in a pilot study versus 54% if you got it from a clinician, so it favored over the counter, so to speak, or self-administration. And then in New York City, people are also more likely to continue with self-administered contraceptives as opposed to clinician-administered. Again, speaking to the idea, if we can get rid of all these barriers and put the power in the hands of people, we're going to see population health benefits. And so, the professional medical establishment is generally quite conservative about sexual health. They want to make sure we're not harming anyone. And so in this country, it's been very hard to move forward this conversation about over-the-counter contraceptives for the past decade. But just this summer, for the first time ever, a company has applied to the US FDA to have over-the-counter status for oral contraceptive. And the American College of Obstetrics and Gynecology, which is the biggest professional body of gynecologists who think about contraceptives, and the American Medical Association, the American Academy of Family Physicians, all the big professional bodies in the U.S. support making oral contraceptives over the counter, because studies have shown that patients can determine, based on self-risk assessment, if oral contraceptives would be good for them in terms of eligibility. It's generally safe. We know now from the data that people actually continue at comparable rates, if not better, and they advocate for no age restrictions. They advocate for no requirement for screening for other sexually transmitted infections, which is a really great benefit when you're having a sexual health intervention, as true for contraceptives as for PrEP. But they want to lower the barriers to make sure that people can access contraceptives. And so they say that STI screening, while beneficial, should not be required. It needs to be low cost for people who do or do not have insurance or have limited financial means. And this should include oral, intravaginal, and injectable contraceptives. It should all be over the counter. So they have spoken in terms of their opinion on this. And I think shifting back to PrEP, where we're, again, years behind, I think we need to try and leapfrog forward and think about how can we accelerate the same conversation. So what do we know about potential consumers of PrEP in terms of their preferences for clinician versus self-administered PrEP? Well, I haven't seen any studies yet about over-the-counter, but there was a really interesting survey of young men who have sex with men in the U.S. asking about if people prefer, in terms of PrEP access, providers leading the decision-making, shared decision-making model, or patient-led decisions, where patients really walk in and ask for PrEP and then get it without having to go through a lot of discussion. And 41%, the largest subpopulation, believed in patient-led. 35% believed in shared and 25% in provider-led. But what was interesting is then they asked these different groups of people based on their preference for who kind of drove the conversation, do they think that they like to and that they should have to kind of talk to their providers about their sexual identities and behaviors? And 0% of the people who wanted patient-led PrEP said that they thought that should be part of the PrEP experience, whereas people who were engaging in shared decision-making or provider-led were more likely to want to have a conversation about sexual health with clinicians. Now, to be sure, there can be great benefits from talking about sexual health in general in terms of having affirmation and other benefits in terms of sexual health and HIV prevention. But we know, based on this study, there's probably a very large population of potential PrEP consumers who are excited to use PrEP, want to have the power to make the decision, and may have experienced stigma from medical professionals, which we know is a common problem for many of the populations who are most likely to benefit from PrEP, including people with substance use disorders, people who are sexual and gender minorities, people who engage in sex work. I mean, all the populations who have had unfortunate ills from the medical establishment want a way to get this without having to go through that very, very traumatic experience of getting health care where they worry about mistrust and frank judgment. And also in terms of convenience. So over-the-counter PrEP could be a really excellent fit for these populations. And there's a quote from a qualitative study in South Africa of a young person who identified as gender non-binary in Cape Town when they asked about access to PrEP and barriers. And this young person said, at the local pharmacy, no one will see you when you go there, and no one will know you. So you will just buy it. That was the dream that this person had for PrEP. And I think this is coming right from the patient's experience. And if you think about the safety of this, which is a really important question as a clinician, I always want to make sure this is safe. PrEP has been well studied and it's extremely safe. There are some considerations in terms of renal and bone health with the TDF-FTC or tenofovir disoproxil fumarate emtricitabine form of PrEP. But they did a study comparing the risk of PrEP adverse effects to aspirin, which has been over the counter for many decades. And 72 people would have to use daily PrEP to cause one case of mildly elevated creatinine, which is a marker of kidney function. But 15 people would have to use aspirin to cause one case of a bleeding problem. So if we think about something we're already comfortable with over the counter, they're pretty comparable in terms of safety issues here. And we know that we accept some risk to provide important access to medications that have important health benefits, like pain relievers and non-steroidal anti-inflammatory medications or aspirin. But on balance, the evidence suggests that this balance would be favorable for PrEP in terms of things like bone and renal health, where if people have risk factors for adverse effects of bone and renal health, well, when you have it over the counter, you could still label in a way to say, talk to your clinician before using PrEP. Now, it's also important to think about HIV testing. And there have been a bunch of studies recently showing that HIV self-testing is feasible in the context of PrEP in sub-Saharan Africa and leads to similar rates of continuation as clinic-based HIV testing, but is considered by patients to reduce anxiety, be more convenient. And the WHO has recently made a statement that they think simplifying service delivery for PrEP is really important. They say that hepatitis B testing is encouraged but not required before PrEP. This is a WHO statement from just this summer. Kidney function testing is optional for people under age 49. And this is something that really will make access to young populations who are the ones who are probably most likely to benefit from PrEP, something that's super smooth to just come in it and get over the counter. And so they think that person and community center approaches are what WHO recommends as the future of PrEP. And so over the counter PrEP, where we already know we have great HIV self-testing technologies, they may not be as good as some of the HIV RNA testing, but they're certainly good enough for getting something out there like PrEP, where the major impact is going to be if we have more users of this intervention. So I'm going to wrap up by saying a quote from Wayne Gretzky, which is a good hockey player plays where the puck is, but a great hockey player plays where the puck is going to be. And so I think the future of PrEP is packaging PrEP over the counter with HIV self-testing. Thank you so much for your time. I really appreciate it.